Welcome everyone. I hope my voice is loud and clear. Very pleased to have you join us today, wherever you are in the world. It's noon Eastern time in New York and Toronto, and 8 p.m. in Pakistan, where our special guest speaker is going to be speaking from today. We have a treat today. We have a very special guest speaker. And I'm also very pleased to have with me two experts on neuroradiology and portable MRI, who I will introduce first after my DI coordinator, Pam Moore, gives kind of a few housekeeping messages. Pam? You're mute.
Mute.
Welcome, everyone. I'm Pam Moore. Thank you for joining us today. I'm just going to go over a couple housekeeping items. So first of all, I just want to remind you that as a panelist, we can't see you, but you can see us. So if you would like to interact with us, you can type questions into the Q&A box. If at the end, we'll have some time to respond to those questions. So use the Q&A box to ask any questions that you have throughout the presentation and towards the end. The webinar is being recorded, and it will be available both on our Queen's Diagnostic Radiology website and also the Portable MRI Journal website. So once the recording is available, I will also send that link to anybody who's registered for the webinar today. During registration, if you did select that you require a certificate of attendance for the purposes of your CME accreditation, I'll be sending those out by next week. And lastly, tomorrow morning, I'll be sending out a short survey that will take about 2 to 3 minutes to answer, just on your feedback regarding today's session, to help us improve going forward and to help us to be able to provide valuable information to you guys. So I'm going to hand it back over to Dr. Islam and Dr. Enam now, and I really hope you enjoy the session, and thank you for joining us.
Thank you, Pat. So let's begin the introduction. So first, for starters, myself, Omar Islam. I'm a neuroradiologist and head of the Department of Radiology at Queen's University and co-editor-in-chief of the Portable MRI Journal. And I'm going to introduce my expert panelists. On my left is Dr. Edmund Knopp. Dr. Knopp has 3 decades of clinical care and research experience in radiology and neuroradiology. In 2015, he was awarded the American Board of Radiology's Lifetime Service Award. Today, he joins us as a senior medical director for Hyperfine, which produces ultra-low field MRI, the Hyperfine soup, which is behind him. Also to my right, Dr. Donatella Tampieri. Dr. Tampieri is my colleague and friend here at Queen's University in Kingston, Canada. Dr. Tampieri has decades of experience in neuroradiology and neurointerventional radiology from both McGill University and Queen's University. And for the purposes of this webinar, she has expertise in portable MRI interpretation. She was, in fact, one of the first radiologists in Canada to interpret portable MRI. She's co-author on a very important publication on portable MRI in remote Canadian setting. It's in the CJNS, Canadian Journal of Neurological Sciences, 2023. I would suggest you check it out if you have not already. It's entitled Feasibility and Cost Analysis of Portable MRI Implementation in a Remote Setting in Canada. Thank you, Donatella and Eddie. So now to the best part. We have a very special guest speaker today on portable MRI from Karachi, Pakistan, Dr. Ather Enam. Dr. Enam is a U.S. board-certified neurosurgeon, a professor of neurosurgery and chair of the Department of Surgery at the Aga Khan University in Karachi, Pakistan. He has a specialist certification in neurosurgery from Canada, a fellowship of the Royal College of Surgeons from Canada, Ireland, and Glasgow, UK, and a fellowship of the American College of Surgeons. He has been awarded several accolades and honors for his work in USA and Pakistan, including the Physician of the Year Medallion, Master Surgeon Award, Excellence in Neurosurgery Award, and the Presidential Award, Sitara-e-Imtiaz. He has a strong interest in basic science research with a PhD in neuroscience from Northwestern University. And today he is going to be speaking to us on one of his passions, one of his many passions, which is portable MRI and Neuro-Oncology Care. And without further ado, I will pass it on to Dr. Enam. Thank you.
Thank you, Dr. Islam. And I'll call you Umar, and I'm Athar. And hi, Eddie, and hi, Donatella, Pam, and the audiences. Thank you for the introduction. One thing I'm not is I'm not a neuroradiologist, so that's a first disclosure I need to make. And I'm not chair of surgery anymore. I have stepped down, and I'm leading some labs in the AKU. So going back to my passion of basic sciences. So my passion is actually global neuro-oncology. That's the main passion, and that made the societies and all that thing. And portable MRI fits in very nicely with that. So with that, a very brief introduction with the thanks to you and to Queen's University and Pam. Thank you for arranging all this thing. And our panelists, been talking to them in the past also. I will start to share my screen. And here we go. Okay. I really think that it's portable MRI is going to be a game changer. When I first time saw it, I was so impressed. People have been talking about it for last, I would say, 5 or 6 years, or maybe a decade actually, about this kind of MRI, but uh, never saw something in actually working condition. It was all ideas and concepts that were people are trying to do. And this MRI that I worked with, Soup, was something that opened my eyes a lot. So I think that this is going to change this whole thing. Let me give you my slide of disclosures. So there is no conflict of interest. Hyperfiner Soup doesn't employ me, although I'm going to use their name repeatedly, and they didn't give me any money for this except for the personal funding from Khan Siddiqui, who was with Hyperfine at some point. He uh, uh, he donated money to hire a research associate who could do these MRI images in a year's time or so. And there's a grant that sort of supports part of the research result that I'm going to show. If you notice over here, let me do laser pointer. Okay. If you notice over here, this is the Pakistan Academy of Neurological Surgery. This is the platform for a lot of educational activities that goes on in Pakistan, and we are trying to expand beyond Pakistan also, and use this platform. Pakistan Society of Neuro-Oncology is something that I formed a while ago, which was very close to my interest in global neuro-oncology. And our sister organization, Pakistan Brain Tumor Foundation of Pakistan, run by wife of one of my patients who passed away. She's very passionate. She's in Canada currently, and she lives there. And from there, she has been able to start this organization. So BTF PAC is more from the perspective of patient care, and PASNO is more of from the perspective of research and academia. And neuroscience is my oldest passion, so I have that in here as well. So I'll start with two cases, and that sort of um, shows the perspective, or gives the perspective of global neuro-oncology. I used to practice in USA when I finished my training. I practiced there for 5 years. I was in Detroit, Michigan, at Henry Ford Hospital, and spending so many years in neurosurgery and then practicing, I have a good understanding of how things are managed medically and surgically over there. And I returned to Pakistan about 20 years ago. And initially, I was very confused about a lot of issues over here. But then slowly and slowly, it has sort of come into a well understood problem that we have. But still, that problem is not totally understood. So here are these two cases. This was a 63-year-old male who presented to me with a progressive decline in mental condition over several months. He came from up north. Pakistan is a country that has more of vertical axis, and brought in by his son, who was in his 30s, and probably that was the sole breadwinner of the family. And for some reason, he had his child with him as well. When I saw this gentleman, he was in bed, somewhat hemiplegic and unable to speak, lethargic. And I looked at it, and I think all the neuroradiologists over here would know exactly what this is. It's a GBM and it's proven otherwise. So I talked to him that we will need to do a surgery, hopefully debulk the tumor, remove as much as it possible, and then go with chemotherapy and radiotherapy. And he was very interested in us going ahead with the procedure. I asked him that, how much, how can he afford that? Because he didn't have an insurance, and that's a problem that we have in Pakistan. Only very small fraction, about 2 to 3% of patients have an insurance. Majority of us do not have an insurance, and we pay it from our own pocket. So he said, "Well, I have some resources." I said, "What?" He said, "I can sell the land that I tell." And I said, "How much would it bring money for you?" That would be about 1/3. So I will speak in Pak rupees terms. So the total expense at that time was coming to about something like 30 lakh rupees when he came. 10 lakh, roughly 10 lakh for the surgery, and about similar amount for radiation therapy and similar amount for chemotherapy. The land that he would have sold would have given him maybe 1/3 of that money. I said, we have a system in AKU where we can take care of the surgery totally free of cost. But then for rest of the things, he will have to sell his land, maybe take some loan. And he was very interested in doing that. But I told him that, look, if you do that, you will have your kids. I think he had 3 children. You will have your kids on the street. You will have to sell your home. Maybe you will not have any way to earn money, and you'll be under loan. If I do everything for your father, and if everything goes well, then the average chance is that he will survive by about 9 more months. If you don't do anything, median survival is 6 months. If you do everything, median survival is 15 months. So for that 9 months of your lifespan of your father, you are going to put everything at stake. And the other option is just comfort care. And so I left, and then next morning I realized that he had gone back to his village up north. I don't know if that was the right thing to do or not. In USA, I would never think about doing that. We will just go ahead with the 1, 2, 3, all the steps that are supposed to be done. But here is a different story. The other person is a 36-year-old female. She came to me, and this is from 2015, 2019. But this is something that has been repeated many times over the last 20 years. So she came to me in 2015. It was low-grade glioma, 1p19q code deleted. We did not used to do IDH and MGMT in those days. Her only follow-up, she came back to me after 2.5 years, and by that time it had recurred. The resection was pretty good over here. The neurosurgeons and neuroradiologists will understand, but then the recurrence was pretty bad, and she was having a lot of seizures, and it was in multiple centers. She never had a radiation therapy. She did not follow up with us, although she was told to do so. But again, she was coming from a long distance, so that was the reason, and we ended up losing her. So these are the two cases that those are the two main categories. One is affordability, one is access. And understanding these things have made me more aware over the last so many years in Pakistan that there are unmet needs for surgery in South Asia and in all LMICs. The BMJ came up with this article. We look at the population statistics over here. This is somewhat old, but Pakistan is coming up to 5 and India is coming to 1. Most of the population of the world is in this area over here. And although China has a big population as well, but then they are not so poor as this part of the world is poor, unfortunately. Now, on top of that, you have to realize that the 50% of the world's population lives on less than $2.50 per day. And because of these expenditures from the pocket, they don't have insurance. The catastrophic expenditure is pretty high. And then about 100 million individuals are pushed below poverty line every year. That's a big number, 100 million individuals. And most of those expenses now it's coming it's coming to be the tumors, oncology. So if you look at this graph, the blue lines are the ones which is neoplasm, and it's projected for 2030. You can see that it's going to become much more prominent over time. The surgical problems, which are like trauma and things like that, those will grow as well. And the annual and cumulative GDP lost in low income, middle income countries from those 5 categories, the neoplasm is the major one. If you compare this to HIV and to malaria and those kind of things, those are pretty much dwarfed compared to these expenses. So this is what is looming ahead of us, and we are walking into it in the next few decades, and we have to do something about it. Asia is where most of the cancers are, but that's because of the population. The problem is that people like us go abroad, get trained, get educated in different specialties, and come back, and we try to manage things exactly as we were taught. And it doesn't work like that. We can't put a square peg in a round hole. The problems in LMICs are different. We have to understand those problems, and then modify uh, um, the treatment plans and our resources accordingly. So there are things like I've written on early tracheostomy over here, and things like cost effectiveness of clipping versus coiling. Coils are very expensive, so there are a lot of things that we have to modify based on LMICs and resources. Yeah, still we try to focus on high ticket items. Some of the man toys, or not man toys, the neurosurgeons toys over here, navigation system and expensive MRIs. And look at this 5-ALA, which is very popular across the world now, that is used to mark the brain tumors during resection. But then the total cost of craniotomy in Pakistan in a private sector is $5,000, and the cost of this thing is about $1,200. So it does not make sense that we don't exactly know whether it affects the survival overall or not. But then using 5-ALA is so expensive, doesn't make sense. Chemotherapy, $500,000 chemotherapy, we can't afford that. Gliadel, I think most of the attendees over here know about the gliadel wafers. I used to use it very often in USA. On average survival was 1.3 months after a recurrent tumor was resected. Uh, and the cost of this thing is about $11,000 or $12,000 back in those days. I've used it only once in 20 years, never used it. It does not make sense to burden a patient with that much unless insurance approves it, and insurance does not approve it. When a craniotomy is for $5,000 and gliadel is for $11,000. So we need to think about different ways of managing it, and we need to make sure that everybody across the country or across the LMICs is educated about how to manage brain tumors. And for that purpose, we are talking about twinning and national international twinnings, tumor boards, and things like that. This is a program that Dr. Noreen Mushtaq started with a group of doctors, and twinning with Hospital for Sick Children. Telemedicine is an important aspect of that. And I think we should only focus on essential technology. So for example, here's a patient with a GBM that I did surgery on. It shows very clearly that it is right next to the posterior limb of the internal capsule, right next to the genu. And although I did have this image and could have used it to guide me through surgery, but that's a more expensive way. A much cheaper way is doing an awake craniotomy and just subcortical mapping. If you do that subcortical mapping, you know where the fibers are coming, and you will stop there. And just using the subcortical mapping, I was able to achieve a gross total resection of this GBM without using an expensive technology. So awake craniotomy is one of those things that fits in very well with an LMIC, although awake craniotomy has been going on for about a century now, almost, well, not a century, half a century now, more than half a century. We used to do it back in 90s also, and then recently there has been upsurge in this technology or technique. And in Pakistan, I started this in 2015, and it has shown some good results. It has definitely shown an improvement in overall survival. It's much safer surgery, and overall it is a cheaper surgery if we can embrace it in the correct way. So it was these kind of things that I wanted to put together, and that's why I started this Pakistan Society of Neuro-Oncology, because my goal was that we have to understand the problems that we are facing in this part of the world. The meetings that we go to, SNO and ENO and all those places are definitely much higher level meetings, but then our own problems are not really talked about and discussed over there. So we need to have our own society, and that's where the concept of global neuro-oncology popped up, and I've been following that for the last 6-7 years. Now, when you talk about a problem, you have to know the problem well before you can start to solve the problem. And that's why Sun Tzu said, know thyself, know thy enemy, 1,000 battles, 1,000 victories. If you look at the data from Pakistan, which is over here, we don't have any data on brain tumors in real sense. We have data from other parts of the country, but not from Pakistan. So we don't know what's the global incidence of Pakistan. There was some data that was coming from Pakistan Atomic Energy Commission, but very low numbers, and the data was very, very basic. So again, with a little support from us, without any grant, we were able to do a Pakistan brain tumor epidemiological study, PV test. This was retrospective data of the year 2019. That was the year just before the COVID started. So during the COVID years, we were studying those patients that were taken care of in 2019 before COVID, and made a consortium of Pakistan Brain Tumor Consortium. And all the information that came out, it was eventually published as a supplement in JPMA on its PubMed index. And there's a lot of information in there that will keep on serving us to address new issues and the gaps that we realized from there. Excuse me. So one of the few things that, and it has been seen in different part of in different studies across the world, that the histopathology is different in different part of the world. So it's not like whatever we see in histopathology in let's say North America is the same histopathology of brain tumors across. So I'm not going to go into details of that, but the histopathology over here was quite different. But the gaps, which are more pertinent to this talk today about the hyperfine, the gaps were, one of the main thing was the socioeconomic status. So the socioeconomic the lower class population in Pakistan is something about 70% or so, but then only 48% of the patients among those that were treated for brain tumors was only 48%. So there was a big chunk of patients who never came to the hospital, who were probably treated by quacks, and or maybe just they died. They could not access the treatment. This data that I collected, the PBTS, this data was collected from those hospitals across the country. There were about these hospitals, which was about 40 hospitals, and about 30 plus contributed in that data. And these were all the centers that were training centers, and most of them were doing brain tumor surgeries. So these were neurosurgical centers, basically. Now, the other difference that I found is that this is the CB Trust data in red. So if you look at the peak age of the CB Trust data, whereas the PB test data shows a different curve over here. We see a much earlier peak in brain tumors. Although the patient population of USA versus Pakistan is different, but still it does not tell us, it does not justify this difference in graph on calculation. The overall demographics suggest that the young adults, 20 to 39 years of age, they are the ones who are getting about 32% of them. The brain tumor the brain tumor patients, 32% of them were younger adults. And then the blue over here is the public sector, and the orange is the private sector. So majority of the patients are taken care of in the public sector institutions. And public sector institutions have their own problem in terms of funding and quality of care. If you look at it, look at this graph over here. Even in the upper middle class, people would go to the public sector. Here, public sector is green, and the yellow is the private sector. So public sector are much more predominant in terms of taking care of brain tumors, and they are not very well equipped. When it comes to distance, this has been shown and published by Lancet Commissions, is that the distance to the hospital is in high-income countries is less than 10 kilometers, and for LMIC is about 30 to 40 kilometers. Whereas what we found that about 60% of patients were traveling more than 50 kilometers, more than about 60% of patients, and about 20% of patients were actually traveling more than 500 kilometers. So that's a huge distance that you have to travel. So that also affects how will you follow up with those patients, because brain tumor is not kind of a surgery or a treatment where you just do it and that's it, it's done. You have to follow up on those patients. The distance traveled, if you look at it, here it is based on different pathologies. So if you look at it, the low-grade glioma and high-grade gliomas, this is the amount of distance that they are traveling. This is a huge amount of distance, and these are the ones that have to follow on a regular basis to see the patient, to get their MRI done, and then treatment adjusted. And this also affected, their survival and all that thing. And I'm not going to go into detail in that data, but that's all in that supplement. Another thing that came up was, and connected to what I've been talking about so far, is the loss to follow up. So about patients that followed up is blue over here, and patients that did not follow up is this. So 40% of patients don't follow up, which is a significant problem. There's not much difference in public and private, but there is some difference though. Um, and then I don't know how this is related to exactly the topic of MRI, but this is something that I find very um, concerning, is that there's a gender bias over here. So I compared the PB test and the CB trust, and the this is the ratio of male to female and male to female over here. And so the PB test and CB trust ratio suggests a gender bias in this one. Anything above one is a gender bias against the female gender. So if you forget the non-neoplastic lesion, I mean, there's a gender bias in there also. But look at these glioma and schwannoma and all those, meningioma. There's significant gender bias over here. Either the pathology is different, or the females are not being brought to appropriate care, and that biases show up in the public and private sector as well. Another interesting thing that showed up in that PB test was this, that about one half to two-thirds of patients, we did not know if they received chemotherapy and radiation therapy. But to put it in a better way, if we look at 778 patients that received glioma, we know that 26% received radiotherapy, 15% received chemotherapy, 21% did not receive radiation therapy, 25% did not receive chemotherapy, and there might be reasons for that. But then we don't have information about 50 to 60% of patients, whether what happened to them. They needed it, did they receive it or not? And if you look at this, we may say that, oh, maybe low-grade gliomas don't receive radiation chemotherapy. But then we're talking about grade 4 also. So here in the grade 4, they did not receive, 14% did not receive radiation therapy. And 55%, we don't know what happened to them. Did they receive it or not? And same thing for chemotherapy. We know that 21% did not receive a chemotherapy, again, financial reasons, and 61%, we don't know what happened to them. Did they receive chemotherapy or not? So these are the big gaps in our understanding, in our management of brain tumors, and we need to address those. We need to understand them more. So we want to move from PB test to prospective data collection. So that's prospective Pakistan brain tumor epidemiological study that I'm trying to start now. And eventually we need to look at the health economics and evaluation of value of treatment studies. So we need to go progressively. But then we can't wait until all those things are available. We need to start to move as things become available. And that brings me to this MRI that we have been talking about, Dr. Islam has been championing. So the MRI, if you look at the this data over here, we don't have Pakistan in it or India in it, but this is the per million number of MRIs per million population. So Japan is pretty far ahead, 55 MRIs per million. And if you go to Mexico, that's like 2.65, and Pakistan is much lower than that, lower than Colombia also. And same thing applies for India, although I don't have the exact data on that one. So the unavailability of MRI becomes a problem, and the quality of MRI is also an issue. And the problem is not only the cost, but the problem is also the distance over here. In terms of cost, if you look at it, the GNI per capita in Pakistan is about $5,680. In 2021, it has gone down actually now, and the GDP per capita is $1,500. Now, put this against the cost of a craniotomy that they have to pay from their pocket, which is about $5,000 if you go to a private setup. And if you don't, you still end up paying about $500 to $1,000 trying to buy medications, and even sutures sometimes they have to buy, because the care that is supposed to be provided by the government is not uniformly quality care across the country. There are small pockets here and there where things are available, but in majority of the cases, it's very chaotic and um, disorganized. So the patients end up paying a lot of money from their own pocket to get treated, and that's where this thing Hyperfine comes in. This portable MRI that we'll talk about. And again, as I mentioned, I'm not on their board. I'm not on their payroll and nothing. But this machine is basically something I've fallen in love with. We've published a few papers on that one, looking at this, intraoperative use of low field. Uh, After systematic review, we reported the first report that was from this part of the world, outside North America, and then using in tropo MRI also. The benefit of this, obviously, is I'm not going to go into details because this talk is not about comparing the ULF MRI with the regular MRI. It's more about the global neuro-oncology aspect. But still, if you look at it, the difference, the power of this thing is obviously it's ultra low field, but then it just takes so little energy, 0.6 kVA. And the weight of this thing is 640 kilogram, and you can roll it. So there are a lot of things that are world apart. And but if you look at though all those things are world apart, but if you look at the MRI, they actually do not look that different. From the perspective of a person that's working in a low resource setting in an LMIC, I would love to have a 3 Tesla MRI, but I don't need 3 Tesla MRI. I need to just find out what's happening inside the head. Where is the tumor? What's happening? Is it herniating? Is there bleeding? And things like that. So I can make my next decision. So if I look at it, if you look at this MRI, 1.5 Tesla versus this ultra low field MRI, it tells me exactly where it is. It tells me what's going on. I mean, there are slight differences in the images in T1, but then as we get used to these images, we should be able to understand very well what's going on with these. So this is 1.5 Tesla over here. This is 0.064 Tesla. This is the post-operative image over here. I'll show you more images over here. So there are some different patients, and this paper is is getting prepared for that purpose. This MRI is, used for a lot of other purposes. For brain tumors, we are the first one who are using it, at least in this part of the world outside North America. So we are trying to publish, put it all together. So here, if you look at it, this is immediate post-op MRI of 0.64 Tesla ultra low field, and this is the delayed post-op MRI. So we don't have this one to compare with, but then the delayed post-op MRI, we have this comparison over here, and immediate post-op MRI of another patient. Again, the delayed post-operative MRI. So if you compare this 1.5 Tesla and this 0.064 Tesla, you do get an idea what was resected, how much was resected. Here's another image over here, 1.5 Tesla, 0.64 Tesla. This is pre-op, so you get an idea of what I'm dealing with. If I get this picture, this is more than enough for me to make my plan. I don't need, it will be good to have a high definition image, but this is more than enough for me to plan somewhere up in the boonies when I come across this patient. And then you can get a delayed post-op MRI, which shows that what kind of surgery was done. And it does give me a fair, decent idea of how well I did the surgery. And here's another example of that patient that shows this 1.5 Tesla, 0.064 Tesla, and comparison of these in the pre-op and in the post-op stage. And this is the last example I'm showing you. So again, this is a high-grade glioma patient. The thing is that we have not been able to go into contrast enhancement. We are looking into that. There was some contrast enhancement. So if we do a contrast, regular gadolinium contrast, and do an MRI, we do see some enhancement, but that's something that is lacking. So if we don't consider the contrast enhancement in T1 varied images, rest of the information is pretty comparable for me to take my action and plan things accordingly. And the most interesting thing was that it was unthinkable to do an introp MRI in an LMIC in a resource limited setting, and even in North America, not every institution has has um, has an introp MRI. But using this machine with such a small footprint of itself, and the Gauss lines are so narrow, we could just bring it in. I did not have to change my instruments. I did not have to, only just we moved the machines a little bit, a few feet away from the patient. This is the operating table the patient was on. The surgery was done. We removed the operating table over here toward the right lower corner, and we moved this in, got the MRI done, and looked at it. How does it look? There are some issues in here, but then we are working on it, how to resolve that. But this is the first time we were able to do an intraoperative MRI in a resource limited setting in an LMIC. And this was a pituitary tumor. So we have this preoperative tumor of 1.5 Tesla and 0.064 Tesla. Intraoperatively, we saw this image, and I was happy with this because I could not really do more than that. And then delayed post-op again, comparing, we see that what we see in ultra low field MRI. So coming to the summary of the ultra low field MRI and the regular MRI, how does it really fit in with the LMIC, with the resource limited setting? There is an issue of inadequate government financial resources, and that's pretty wide across all over the world in LMICs. The imaging amenities are restricted to metropolitan settings only, so we don't see this in small towns and other areas, and that's why patients have to travel 50 plus kilometers and maybe up to 500 kilometers. There's a limited number of trained technicians. There's always a shortage of those, because those who get trained, they are just picked up, they are sucked out into some Middle East or some other country because they get a better pay over there. So we are always have a shortage of trained technicians. And the MRI vendors, obviously, there are a few MRI vendors, and there's somewhat sort of monopoly, which causes inflated costs over there. And since the MRIs are not enough, there's a non-uniformity of quality of scans, and the supply of electricity is always an issue. Right now, as I'm speaking, in the back of my mind, I have this fear that the electricity may suddenly go off, and I will have to start my generator, which will interrupt this for about a minute. But this is an issue all over the country. And then the regular maintenance costs and operational costs are much higher in the conventional MRI, and the patient safety risks are also an issue. So if you look at the conventional MRI and the portable MRI, so a flare in the portable MRI just takes 4 minutes. It takes 4 minutes, and it's much quicker. You can roll it very easily. The interesting thing is that one can train, and we have data on it. And Altaf, who actually made this image, he is preparing a paper for that purpose. That you can train a medical officer, a resident, to run this MRI in half an hour, whereas to train for on a conventional MRI, a technician, that they need weeks and weeks of some kind of a course and then tests and all that thing. And we can do it in half an hour, and these guys can roll the MRI. It's easily to roll, and get this thing done in under 30 minutes. The whole thing is done, and the beauty is that I can get it done in the immediate recovery room area, in an ER setting, in an ICU setting, and most of all in the OR. So those are the benefits. It's a small machine that can go through 34 inches doorway, so we don't have to have like big doorways and all the thing. So it's a wonderful, it's a disruptive innovation that will change significantly over time. It has been going through a little slow pickup. I don't know reasons. I know I don't want to discuss at this point over here, but I think the cost is going to come down, and this will be the way to deal with the MRIs for brain tumor management, global neuro-oncology, and LMICs. Things, portable machines like these are going to make the difference. The interface of this machine is so simple, and the data, the image that is collected is pushed onto the cloud, and the experts like Eddie and other people can look at it and comment on those things. So we are working with a group in Harvard. Key Park is a very strong global neurosurgery advocate. working with him, and one of my research associate, Shakir, is working on that one and preparing the comprehensive health system policies, recommendations for management of brain tumor and LMICs. And in that, the mobile ultra low field MRI is coming up as one of the main things that we need to have to improve the brain tumor care in USA. And this is my team, who worked on different aspects. Altaf's picture is big over here because he was the one who was the main person collecting the data on the hyperfine MRI. And with that, I come back to this, The Art of War by Sun Tzu, that know thyself, know thy enemy, 1,000 battles and 1,000 victories. Thank you very much. I appreciate your patience.
Thank you very much, Dr. Enam. Wonderful presentation, really an eye-opener. Even for some of us who've been working with portable MRI and know its advantages in terms of access. Thank you for providing the valuable insight into all the challenges and also the opportunities that exist in Pakistan and elsewhere in advancing neurological care. And the message that to me that resonates is your dedication over multiple years and decades to improving care for underprivileged patients in Pakistan and elsewhere. So thank you very much for that.
Thank you.
So
I had requested. Maybe I should have done that. I asked Eddie to just jump in and say things about those MRIs, but then I guess it's open now. If you want me to go back, because I said I'm not a neuroradiologist.
You did an excellent job, Ather.
Yeah,
No
I'm a
problem at all.
simpleton. I'm a simpleton. I know. Tell me here to cut. I cut there, and then I say, "Does it look good?" And you tell me, "Yes, it's
It looks
okay."
good.
Right.
well, I mean, that's one of the advantages of portable MRI. The images are different, but they're
Right.
still good enough quality for the purpose that you tend to do them for, that you get your answer. So no, thank you. I saw your excitement in sharing those images, so we just let you keep going at it. So it's
Exactly.
so I have a couple of questions here, and then we'll open it up to the panel for other questions and comments. So the first question I have here is, how many portable MRIs are there in Pakistan so far? And is there one in KPK? I don't know what that means. Maybe perhaps you do.
Right. So this suddenly makes me realize I made a mistake. So the portable MRI that I was using over here was obtained from Belinda Gates Foundation research grant, which was given to pediatrics. They're looking at the nutritional effect of brain development in pediatric cases, and I just asked Faiza Jahan, who was the recipient of that grant, that if I could use this MRI. She was very kind enough. So we've been using this MRI for other purposes, but actually the MRI was brought in from that. So we never bought this MRI. I know JPMC has bought one. That's the public sector institution over here. But as far as I know, there are only two MRIs. One that we used, and we have, used it so much that it's burned out and it needs repair. And the other one was probably never taken out of the box. And that's the typical story that happens in public sector institutions.
Just my follow-up to that, out of curiosity, how many do you think you would need, in a country like Pakistan, for kind of just putting a dent in some of the neuro-oncology care issues that you've outlined?
So I showed that figure. KPK is one of the provinces, and I'm not aware of any in KPK except for these two in Pakistan. So the population of Pakistan, it keeps on changing. It's about 250 million, right? So if you notice that in Japan it was 55 per million, right? And in Colombia it was like 0.26 per million. So even if we take a 0.1 per million, we need about 2,500 MRIs in this. Sorry, so 25 MRIs like these, but then what will give us an adequate distribution of MRI across will be at least 2 or 3 per million. So that brings it to about 750 or so. If you look at the ratio, is much higher in North America. Japan was the highest. So at least 2 or 3 per million is what we need. It should be positioned in every district hospital, in every tertiary care center, where you can just roll it and get the MRI done. So we're talking about a few hundred MRIs. The thing is that the cost of building up this bunker for the MRI, I mean, although we don't call it a bunker we call it for radiation therapy, but still we need all this lead and all that, and large space and office and hospital spaces are pretty expensive. Uh, so the the cost of this MRI for some reason is still high because it's in an R&D stage, and it is slightly lower than let's say 1.5 Tesla MRI of some of the known entities, known companies. But then overall, putting a regular commercial MRI is much more expensive, and this is going to come down. So once it comes down, we have all these MRIs spread across the country. Uh, it should be at least uh, a few per million population.
Thank you. I have another question for you, and then I have a couple for both Dr. Tempieri and Dr. Knopp in the chat. So this is from Benoit Sai, who's I know well from UpCare here in Canada. His question to you is, in terms of intra-op, when do you bring the system in post-resection, and have you used it for brain shift?
So I have not used it. That was the one year I used and published it. I plan to use it more, but then the MRI had some issue. It is in repair. But yes, you can use it for looking at the shift because it's just like a regular MRI. The only difference is the regular MRI that they have, a drop MRI. It has slightly higher Tesla, so slightly better imaging, but not as good as 1.5 Tesla, but enough for them to see that what's happening in terms of the shift and all that thing. The beauty of this is that I don't have to get new instruments. I don't have to move things around. I don't have to shift the patient from this bed to the other bed, because typically the introp MRI is located in a separate room, and the whole bed is rolled over there. It's like in a small OR, you can just roll in the MRI, get it done, and move it out, and that will give you a clear-cut idea of the shifts and the bleeding and hydrocephalus and whatnot, and the amount of resection.
Thank you. One here for Eddie's. So from someone anonymous, from Hira Wahid. How much time does it take to construct an image? Usually the conventional MRI takes more than an hour.
The images display on the interface for the scanner, which is actually an iPad at the point of care. As the image is being created, you start to see that image displayed. So in the case of massive brain shift or massive hemorrhage, you're going to see that before full image reconstruction. The sequences are slightly longer than high field, but the image reconstruction time is an additional, for full reconstruction, including AI enhancement, it's about an additional 1 to 2 minutes. So let's say for a fast T2 weighted image, it's 2.5 minutes to scan, an additional minute to reconstruct. So in 3.5 minutes, you'll have the ultra low field diagnostic image, T2 weighted, showing mass effect in the brain, brain shift, herniation, hemorrhage, and the like. So it doesn't take orders of an hour. I don't think high field does either, but it's all done at the point of care on the scanner itself and can be visualized on the scanner before it's distributed to whatever system is in the institution.
And from my understanding, Eddie, you can modify the protocol. So if you just want a diffusion image or just want a T2, that you can stop after 5 minutes and get your diffusion and move on.
Right, that's correct. I think Dr. Enam kind of elaborated, in fact, that anyone can kind of run this scanner. It does not require a licensed MR technologist because it's very, very simple. To that extent, you select what sequences you want to use for the purposes in which you're looking at the study. So if, let's say, you want to do a ventricular check, an assessment, you do a quick T2 and you have the answer. That's what you pick and that's what you select. Makes it very simple, very straightforward.
And a follow-up question. This is from Dr. William Miller, colleague of ours from University of Ottawa. How good is this MRI at detecting hemorrhage?
So when we talk about hemorrhage, all different types of hemorrhage, macro hemorrhage, whether it's intraparenchymal or extraaxial. It is readily detected. In published literature that came out of both Yale and MGH 2 years ago with older hardware and significantly older software, they were saying image resolution of about 4 millimeters. Again, I think the point is, and Dr. Enam elaborated on this, we're using it to answer specific questions. And in this setting, you're going to answer that question. Where we don't have resolution, all cards on the table, is that microhemorrhage. So the hemosiderin staining and whatnot. But in the acute setting, that's not what you're looking for. So I think subarachnoid hemorrhage we can see, extraaxial collections we can see, intraparenchymal hemorrhage, and all the resultant effects of those hemorrhages, mass effect, edema, and the like, readily discernible to approximately published 4 millimeters. I've seen anecdotal cases now 2 to 3 millimeters in size with the new softwares.
Thank you. I'm going through some of these questions. Lots of questions. Please keep them coming. Lots of great topics all over the map for all of our panelists and Dr. Enam. This one, I'm Donatella. I'm going to pass the buck on to you, but maybe I can jump in as well. This is from another one of our colleagues, Dr. Jeff Chernkowski from McGill. So his question is, in the Canadian environment, do you think there will be a resistance to non-MRI techs operating these portable units? Unions will object. We barely have enough techs to run our fixed MRI. I punted that one question to you because it's a tough one, but maybe I can add some comments as well after you're finished.
Thank you, Omar, for the nice question. Thank you, Jeff, for the nice question. Well, of course, it's always unpredictable to know what you can receive as a grievance from a union. With our experience in remote region, as Dr. Enam said before, the handling of the unit is very simple. It can be run at bedside of the patient. The security is not the same that we have to observe either for the 1.5 or 3 Tesla. And the purpose of the unit is really to provide medical care, as Dr. Enam really underlined in his tremendous work in remote region as well. So I foresee that there should be some room for the use of the machine by either PA, physician assistant, a nurse, or a physician assistant technician, or resident if available in the remote region. But I don't think the requirement of security are the same, but for a regular MRI.
Thanks, Donatella. Just to elaborate on that, and for our project with portable MRI in Moose Factory, for people who don't know, is close to 1,000 kilometers north of Queens and Kingston. We had a retired family doctor operate the machine, and after a half an hour of training, my colleague Aditya Bharata, Dr. Bharata at St. Mike's at University of Toronto, who has a portable MRI in their ICU, they ran into this issue when they first got the MRI. The Ontario Association of MRT has come down with a decision that any technologist can operate the MRI if they have some training and the requisition is signed by a physician to run the scan. So I believe in their institution, it's not MRI techs necessarily, it's any X-ray tech who's operating the machine. So that's potentially one solution, at least in the Canadian environment. Let's see, lots of questions here. I'm trying to see what we can get the next 2 minutes.
There's one question from Noor Malik. She was my trainee. She's in Toronto now. She was at Denver. Her question is, how much does it cost to the patient? So this was being done free as part of research, but then cost of the patient must be very low. It's about it's about $20 in a very cheap MRI units in Pakistan, to $180 in an upper end settings per MRI, which is much different than the MRI cost in North America. But once we have this thing, I think I can imagine it's going to go down below $10 per MRI, even up to $5. It just have to be number of MRIs that you can run out of this machine. and divide it by the number of patients. So it's going to be less than $5. Okay,
Just
sorry.
to elaborate on that as well, one of the costs or the drawbacks for MRI is the operating expenses, at least in North America and Europe. It's cost a lot of money to operate a machine for electricity, heating, cooling, building. And for this, it's negligible, right? It plugs into a wall outlet, uses the same power as a coffee machine. You can move it anywhere, can be stored anywhere. So, after the initial purchase cost, the operating expenses are extremely low. So when you budget for this, that has to be taken into consideration over the long term. I think that's where some of the real benefits come into play for low field MRI. So this question I think I know the answer to, but I'm going to let the experts answer this. So this is from Udana Azodo. Sorry if I'm mispronouncing the name. Professor Enam, thank you so much for a very enlightening and informative presentation. What is your impression on the use of portable MRI for diffusion tensor imaging on brain tumor surgical planning, and if it can provide comparable clinical support like conventional MRI?
So, Eddie is going to come up with the DTI protocols for that. Right now, we're looking at the basics. And the point in my talk was, we can have all these tractography and whatnot, but if you have to take care of a patient in a setting where there's hardly enough of OR lights, there are parts in Africa and in Asia where there are very limited resources. All a neurosurgeon wants to know, hey, where is the tumor exactly, and what happened to it? Is it bleeding? Is it herniating? And what's going on? You can have some clinical exam, but get an MRI and get done with it. But then the way it is, I think the DTI and all those things, tractography is coming in few years. But I think Eddie or Donna can probably give a better answer to that.
Thanks, Ather. So what I would say is currently conventional diffusion imaging without the ability for tractography. That being said, and we kind of saw some indication on some of the slides we saw, the image data is capable of being fused with pre-existing higher resolution and advanced imaging techniques on neuronavigation systems. So you can have the best of both worlds. You can look at your hyperfine swoop image overlaid on the preoperative DTI image, if you have it, and see where things are. Has the tumor grown? Has the tumor not grown? So it's that capability that is possible as of right now. But DTI itself from the scanner, not currently available.
One other question. I think Dr. Enam, you answered that in text form, so thank you for that. I think the other three questions are similar. What is the slice thickness? Can it be changed? Does it have the same resolution as a closed MRI? And I think we know the answer to that. Eddie's already answered the resolution question. But in terms of slice thickness, can it be changed, Eddie?
Currently, right now, the purpose of the system, as we've heard, is to be able to be used anywhere by anyone. So adjustments of parameters, we've intentionally locked that down. So out of the box, the system has conventional imaging slice thickness of 5 millimeters, diffusion imaging slice thickness of 6 millimeters. All of the sequences are obtained in a 3D fashion. So there's no interslice gap, and they can be manipulated and reformatted. But again, slice thickness 5 millimeters or 6 millimeters and not adjustable at this point.
Thank you. So there's another question by Wahid Alam. What is the price of hyperfine MRI? And I don't know if we need to go into that because it probably varied based on country and locale. I'm just going to redirect people if they want to look at the cost benefit of portable imaging versus conventional imaging. Our published article and that Dr. Tampere was involved in Moose Factory. In that study of 18-month study, the cost saving for a portable MRI in a remote community was approximately $8 million Canadian over 5 years. And the bulk of that savings was in transportation expenses as well as nursing costs, and then obviously operating expenses for the unit itself. That did not take into consideration any cost savings that are incurred from quicker or easier access for patient and improved patient care and lifespan. that was not assessment of brain tumors only. It was assessment of any neurological condition of patients presenting to the ER in Moose Factory, Ontario. So it's definitely a significant advantage from the cost-benefit analysis in remote communities in Canada, and I believe those results are could be expanded across the world. Dr. Enam?
Yeah, I just wanted to maybe I'm stepping onto some not politically incorrect territory now. The cost of this machine a couple of years ago was about $400,000, which is comparable to an MRI of a mid-quality MRI from another company. The thing is that in LMICs, there's a big market of used MRIs which are being sold over here, and those are much cheaper. So a conventional MRI, one can obtain a used conventional refurbished MRI much cheaper, but this MRI its cost is going to come down eventually. It's in an R&D stage at this point. 5 years from now, it's going to be much cheaper. Just look at the size of the machine; it's all metal, So technology is there, but eventually the price goes down.
I think regarding cost, the one thing I would add is there's no siting cost, right? Dr. Enam talked about the MR room and the shielding and everything. There's zero siting cost, just a 15-amp electrical circuit.
Absolutely.
That's what existing everywhere. So that significantly reduces any sort of cost that's there.
Absolutely.
The last question I'll answer, and then I think we got to close because we're over. We could keep going on and on. We'll have to plan for the next webinar. Dr. Jankowski, part B question, is there plan to image other parts of the body in the future? I know there's work being done worldwide, not just with Hyperfine, but with other vendors in the future to look at other body parts. And maybe last word on that from you, Eddie, for Hyperfine itself.
So at the present time, all of our efforts are directed at brain imaging and brain imaging alone. We're a panel of neuro-related specialists, so clearly the brain is most important to all of us. But going down the road, we don't know what the future holds. Obviously, with the present form factor, I don't imagine being able to do cardiac or chest or anything. It's not going to quite fit. But that being said, brain imaging right now, and from my standpoint, and I imagine my co-panelists would agree, that's the most important thing at this point.
Yes, thank you. Thank you. So I think we will close there in terms of the Q&A. Pam, if you could just put up the one slide. I'd like to, whilst you're doing that, I'd like to thank our very special guest speaker, Dr. Enam. Thank you very much for a wonderful talk, opening up our eyes to all the challenges and opportunities in Pakistan and around the world. Very nice to have you on board at, took out your evening to come join us. Dr. Tempieri, Dr. Knopp, thank you very much as well. Again, excellent comments and your expertise is much appreciated. And of course, Pam Moore for helping us keep this organized and on time and schedule. Thank you. The last slide here is for those of you, and there's a significant number around the world who've asked to view this after the fact because of time differentials. These are the two sites where the video will be posted in the next few weeks in our Department of Radiology Queen's University website under special events, and also on the Portable MRI Journal website under webinars. It's also available on the Portable MRI Journal YouTube page at Portable MRI Journal. So please look out there for this and all the previous and future webinars that we plan on holding. So thank you very much, everyone. Thank you for all the participants and the questions, and we'll see you next time.
Thank you. Thank you very much.
Bye-bye.
Thank you for having me. Thank you.